Greetings from eMediNews. Now we are going to talk about antibiotic prophylaxis for preventing surgical site infection. Antibiotic prophylaxis is the use of antibiotic to prevent infection at the surgical site. The Center for Disease Control and Prevention recommends antibiotic prophylaxis for all clean contaminated procedures and some clean procedures which involve implantation of prosthetic material or those procedures where post-operative infection has been severe consequences, for example neurosurgery, open heart surgery and ophthalmic surgery. Contaminated or dirty procedures are infected and so are already on therapeutic antibiotics and do not require prophylaxis. Let us now briefly review the three basic principles of antibiotic prophylaxis. An appropriate antibiotic prophylaxis should be safe and inexpensive. It should have an antimicrobial activity against the pathogens most likely to be encountered at the surgical site rather than against every possible pathogen. So, an antibiotic with the narrowmost spectrum of activity required should be selected. The use of broad spectrum antibiotics should be avoided for surgical prophylaxis to prevent the development of resistance. The antibiotic should also achieve adequate serum and tissue levels. First and second generation cephalosporins are the preferred antibiotic prophylaxis agents for most surgical procedures. Procedures involving the distal small bowel, appendix, colon and rectum and gynecological procedures require anaerobic coverage. Hence, second generation cephalosporins with anaerobic activity such as cefoxitin or cifotenan are chosen for prophylaxis, or an antimicrobial agent such as clindamycin or metronidazole may be added to the other first or second generation cephalosporins. For patients with significant beta-lactam allergies, vancomycin or clindamycin is recommended for gram-positive coverage and aminoglycosides or fluoroquinolones are recommended for gram-negative activity. Antibiotics are usually given intravenously. Through a combination of oral and intravenous administration can also be used. It is also important to ask the patient about a previous history of antibiotic allergy. Timing of administration of the antibiotic is crucial to its assigned role as a prophylactic. Most surgical site infections begin with 2 hours of contamination. The perioperative period, therefore, is the most crucial for development of surgical site infection. The antibiotic should be given before the surgery, ideally within 30 minutes and definitely within 1 hour of the incision time. This ensures that antibiotic levels in the tissues and serum are optimal at the time of incision and maintained for the duration of the procedure. For longer operative procedures, the antibiotic may be re-administered intraoperatively at 1 to 2 half-lives of the antibiotic for the duration of the procedure. Antibiotic prophylaxis should not be continued beyond 24 hours following major surgeries. However, antibiotic prophylaxis for cardiothoracic surgery may be continued for up to 48 hours post-operatively. Administration beyond the recommended duration not only increases cost of the treatment, it also favors emergence of resistant bacteria. Prolonged use of prophylactic antibiotics also may mask signs of established infections, make diagnosis more difficult and prevent patients from receiving timely and adequate treatment. Prophylaxis regimes have been recommended for a wide variety of most commonly performed surgical procedures. For example, cardiothoracic surgery, cefazolin, cefuroxime are the recommended agents. For vascular surgery also, cefazolin or cefuroxime are the recommended agents. Gastroduodenal and open biliary surgery, cefazolin is recommended. For colorectal prophylaxis, cefoxitin, cifotenan or cefazolin plus metronidazole is chosen. For hysterectomy, either cefazolin is the preferred drug. For gynecological surgery, clindamycin with either gentamicin or quinolone is chosen. For orthopedic implantation surgery, cefazolin or cefuroxime is the preferred agent, and for head and neck surgery, either cefazolin or clindamycin is prescribed. To summarize, all clean contaminated and some clean surgeries require antibiotic prophylaxis. Broad spectrum antibiotics should be avoided for the purpose of prophylaxis. First or second generation cephalosporins are the preferred antibiotic for most of the surgical procedure, with addition of either metronidazole or clindamycin if anaerobic prevention is required. Antibiotics should not be continued for more than 24 hours. And now in the next module, we will discuss about hand hygiene.